Buenos días desde Alicante. Estamos en ARI23 y vamos a comenzar este día luminoso de Alicante con una sesión muy interesante sobre córnea y superficie ocular. Sin duda alguna, la córnea y superficie ocular son los grandes protagonistas de la cirugía actual del segmento anterior y ciertamente que merecen estas dos sesiones que van a versar. La primera, la sesión 3, de cómo tratar casos complejos de superficie ocular, mientras que luego tenemos una sesión cuarta en casos de córneas complicadas. En esta sesión que vamos a comenzar ahora, en la sesión 3, vamos a tener distinguidos ponentes que van a tratar sobre distintos temas complejos de reconstrucción de superficie ocular. E iniciamos esta sesión con la keynote de Rohit Sethi sobre nuevos fármacos en el tratamiento de la superficie ocular. Rohit, tienes la palabra.
Hello, friends. Thanks for this opportunity. I'm going to speak today about new drug for the treatment of ocular surface. These are my financial interests. I do receive grants from these companies. When we look at understanding the dry eye or anything to do with the ocular surface, we have to understand the ocular microenvironment. And dry eye, changing microenvironment is increasing the range of incidence of dry eye from 5 to 50% in different published works. And what is important here is the whole concept about dry eye, the desiccation stress, and the ocular surface damage is mediated immunologically through an efferent and efferent arm. The antigen-presenting cells from the surface with all that changes which is happening and brings to the draining lymph nodes, and through your T-cell mediated response, you see a lot of changes which is chronically happening. Initially, it's a protectant, but again, after some time, it becomes a chronically affecting the ocular surface. This is a work done by our group on using a holotomogram on ocular epithelial cells. And you can see that when in a healthy thing, you can see this is a dead cell being eaten up by the living cell. And the ocular environment is very healthy immunologically. In an inflamed eye, when you like this, when it's a tremendous amount of stress, you can see that the cells are in the desiccation mode. And desiccation mode is something which is exactly what I just mentioned here. These kind of things has been replicated in the images out here. It just shows that the power of dry eye on epithelial cells and what it secretes. So what are the immunomodulators? Because now we understand that dry eye is immune response, altered immune responses. There are a lot of factors which are happening: free radical release, apoptosis damage, complement system, different proteins. There are different antigen antibody responses out there. And what we require is we need to prevent apoptosis. We remove the inflammatory aspects of it. Promoting cell healing is what we need. Specifically in our process. So dry eye has become extremely personalized care now. See, an empirical treatment, a blanket treatment, we had to move out of that mode of a complete blanket treatment to make it very, very personalized. And that's what the whole focus is. That's what the new drugs are focusing. So how do we customize this? One of the biggest knowledge gaps is to identify what immunological changes are happening in your ocular surface. And that's why in this paper, it mentions clearly the TFOS1, which talks about what tests can be useful. So what we developed for the first time in the world is using the tear Schirmer strip and extracting the proteins through a buffer. We're able to do in OPD of lab test, which we call the biomarker pathfinder. This is the first only tool in the world which can give you a battery of biomarkers which are involved in the ocular surface. And this is a simple video which explains about taking a Schirmer strip, like how you do a dry eye, putting it into an Eppendorf tube. After some time, just use a buffering surgery which leaches out those cytokines and proteins and shake it well to make it leach. And this is a fluorescent reader. You put it and after 90 minutes, you get this report. In this report, you can see that you have all these IL-6, IL-1 beta, 17A, all these things which has been hugely implicated in the dry eye model across the world. And we have also done an reference here. Now we have built an AI platform on it, and you can see that this is an abnormal values. You know that one shot, you know what cytokines are abnormal at what level. And now we have an AI built model which explains about how these cytokines have an impact on the ocular self, and we control with dry eye with the control. We also now looking at a model using the biomarker kit where we use and titrate the drugs accordingly, which I'm going to discuss in my next few slides. What drug works well? If it's a combination of these, the IPL therapies work well. If it's an IL-17 with TNF alpha, doxycycline may work well with intense pulse therapies, or an MMP9 with ICAM1 can work maybe with ICAM1, as I'm going to discuss, is a liftigrast, the antagonist molecule. So there are a lot of these kind of factors which can be used in a biomarker studies. So this biomarker can be a huge impact in the way we prescribe drugs, both in refractive surgery, monitoring the patients, and what drugs to use. Let's look at the new perspectives of cyclosporin. We used the same desiccation model, and you can see that when you use the cyclosporin on a desiccation model, it suddenly makes the cells to start becoming better, and the cells start regenerating, and you can see the less of cytokine induced. This study Essence-2 trial does show the new one in JAMA ophthalmology, which shows that suggests that effect is clinically meaningful in 71% of the groups which they studied. The second one is the liftigrast. Liftigrast works on antagonist that blocks the interaction of ICAN, intracellular radiation molecule, and LF1, which is here, and inhibiting the T cell mediated immunity. It is very important that the antigen presenting cells, the DCs and human epithelium, and when you mix it with, when the LF1 mixes with ICAM1, that's when he activates the T cells. That means the T cells gets activated when the ICAM1 with the LFA1. The LFA1 is a lymphocyte function and associated antigen. So if you block this whole merger, you're able to bring in less of T cell activation and all that it creates. So what it does is it blocks the LFA1 here so that it reduces the merger. So you can see that this whole thing with and without liftigrast, you can see that T cell activation is grossly reduced. When the T cell activation is reduced, all that changes which it brings is also reduced. This is very important function of the liftigrast. So we did a small study which looked at the basic parameters of one eye. We used the CMC, other one is the liftigrast. And what we found was the liftigrast, which is in blue here, was good in OSDI, improving the T-bud, increasing the stemmers, and reduction in the staining score. Virtually, it's good in every other parameter studied. We also know that because it drops the T cell activation, it is known to affect the MMPs, the TNF alphas, interleukin gamma, and IL-17, IL-1. And what we did was, based on my biomarkers, I was able to assess the tears of the patient who had the liftigrast and other eye had the CMC. And you can see that the tremendous amount of changes, it's a fold chain. That means pre and post. It's a fold chain it is bringing in. And you can see that all the molecules which we know, the TL17, TNF alpha, IL-10, and IL-6, as it's given, most of it is given here, it brought in a drastic change. So that means that liftigrast does have a huge impact in bringing and modulating the immune mechanism. But one of the areas which we are studying is looking at the ICAM1 specifically, and we are seeing some changes which I'll present in maybe in the future meetings, where it specifically blocks the ICAM1. What are the newer drugs? The insulin is one of the new things which has been mentioned. It's a hormone, plays important role in cell growth, metabolism, and hemostasis. We all know about insulin. There's a huge area of interest in wound healing, reepithelialization, especially as an ocular surface is concerned. And what we feel is that it has work on reepithelialization, wound healing, cellular proliferation, increase the metabolism, and in animal studies, it's also known to increase corneal cell morphology, corneal nerves, post-LASIK dryness, and multiple areas. And this is some of the The dosage which is used, zero point 0.1 international units per ml to 100, it's been used. No adverse effects have been used. And this has been used from epithelial defects to neuropathic keratopathy, persistent epithelial defect, burns, dry eye in diabetic patients, neuropathic ulcers, and corneal wound healing after vitrectomy. You can imagine the number of studies being done, and this gives you also a nice overview of what type of what the dosage which has been used. Coming to the other drug is trehalose and autophagy. Autophagy is the housekeeping mechanism of the eye. Trehalose, like cyclosporin, has an impact on autophagy, which is one of the mechanisms of inflammation, according to this paper here. And you can see that this is a basal condition. We induced stress in this condition, and you can see that these are lysozyme trackers, and you can see that it induces autophagy, which means that it's making the cells to revive and clean the dead cells. And this is a simple paper which explains about trehalose with the CMC. We use trehalose with sodium hyaluronate, and this sodium hyaluronate works like a lubricant. Trehalose is one of the active component which reduces the inflammation here. The other new drugs like macuberry. Macuberry is it is extract. It's a berry extract. It is used in a lot of diabetes control. It works on the NF-kappa B inflammation, and we again did some studies which explains the role. And you can see that the one in the purple is macuberry. You can see that it did have an impact orally without using any drops. It did impact on the dry eye, and also interestingly, it had a lot of molecular level impact on the ocular surface. To conclude, the whole immune mechanism on the ocular surface has to be understood and harnessed. There's a huge potential of liftigras. We know that it works on the T cell activation, and it works on the pathways, and biomarker work has proven that it does seem to work on those specific markers. Insulin has a huge role, but the dosage needs to be understood. Huge role in a lot of neuropathic related stuff. Oral macuberry and the berry extracts definitely has a role because it works on, as I mentioned here, on IL-10, which is a protectant. Though increased IL-10 has an impact on protective aspect of ocular immunology. And we had to look at the biomarker-based studies to look at the proper use of these drugs. I thank you and thank my team for this presentation.
Thank you, Rohit, for this most outstanding and interesting keynote. And now Maria Gesa, my co-coordinator of today's session 3, is going to introduce the next speaker. Maria.
El siguiente ponente es Guillermo Amezcua, de Miami, y nos va a hablar del manejo del déficit limbar. Le escuchamos.
Hi, thank you very much for the invitation to speak about limbal stem cell deficiency and the management. My name is Dr. Guillermo Amezcua, and I'll be sharing with you today some parallels about the management of this complex situation. I have no financial disclosures for this talk, and I think it's very important to understand the concept of how the ocular surface needs to work in harmony. There should be a hemostasis in order to maintain the health of the corneal and conjunctival epithelium. The surface needs to be wet, needs to be well protected by the lids, well innervated by the nerves with no neurotrophic component, and all this in order to maximize the function of the limbal stem cell niche where the limbal stem cells are located. When there's damage to the limbal stem cell niche, the patients will develop a conjunctivalization of the cornea with neovascularization, superficial neovascularization of the cornea, persistent epithelial defects, and pain and photophobia. It's important to categorize the limbal stem cell deficiency. I like to split in two wet and dry conditions, or non-inflamed with inflamed situations. The other way to look at this is unilateral or bilateral, but I think it's very important to know if the surface is wet and well protected with good eyelid function, or if the surface is very dry and is very inflamed with progressive cicatricial changes, because that's going to depend on the management of these patients. When the patient has damage to the limbal stem cell niche, either unilateral or bilateral. The role is to restore this in order to promote good corneal epithelium growth and reestablish the corneal clarity. And it's important to know that not all patients with damage to the limbal stem cells need surgery or need an intervention. It's a surgical intervention. Many of these patients, especially these patients with bilateral progressive cicatricial disease, the control of the inflammation is very important. Like this patient with progressive cicatricial disease, secondary to severe atopic and a biopsy-proven cicatricial conjunctivitis secondary to pemphigoid, that after 4 or 5 months of anti-metabolites with mycophenolate, we were able to quiet the ocular surface and remove the white cataract that she had successfully without any complications. You can see how the pre and post with the proper anti-inflammatory therapy. We need to be aware of the classification, the international classification, the limbal stem cell deficiency working group, in order to have the different stages of this disease. And because this study will give the recommendations on how to or what to offer to these patients with limbal stem cell deficiency, if it's unilateral, if it's bilateral. And for the interest of this topic, I'm not going to talk about keratoprosthesis because that's a completely different topic, but we'll touch on some of the procedures that can be done. But before we do anything, it's very important to read this manuscript from the group of Dr. Schaefer-Sang, and here Dr. Espana clearly points out very important things that we have to do before we start offering surgery for restoration of limbal stem cell deficiency. We need to make sure that there's no aqueous deficiency, that there are no cicatricial changes affecting the ocular surface, that if there's exposure neurotrophic component, that needs to be resolved before the surgery. And very important, if there's an active cicatricial process, we need to offer immunosuppression. So like I was saying, all is going to depend if the patient has unilateral disease or bilateral disease, if the surface is wet or very dry. If the surface is wet and is unilateral, we can offer these 3 options for the patient: conjunctival limbal allograft, cultivated limbal epithelium, or simple limbal epithelial transplantation. And if the patient has bilateral disease, we're going to have to offer allogenic tissue, either from a living-related donor or from a cadaveric donor. And the limbal allograft is very well described. Lots of experience on this surgery, works really well. The only problem with this is that we need to harvest a significant amount of limbal from the contralateral eye, with a small to minor risk of causing limbal stem cell deficiency on that eye. The alternatives for something like this will be something like CLET or SLET. Cultivated limbal epithelial transplantation was well described in the New England Journal of Medicine by the group of Dr. Pellegrini and Pablo Rama in Italy. They show a 70 to 75% success rate on these patients, but it needs an expensive laboratory in order to accomplish this. I believe in Europe there's a company now, Holklar, that offers this as commercially available. We don't have that in the United States. The group from LV Prasad has lots of experience in CLET. And I was actually interested in this, and I flew to Hyderabad in 2011 in order to learn this, but I ended up learning more about SLET. It was about the time that the group in LV Prasad, led by Dr. Sam Basu and his mentor, Dr. Virender San Juan, where they started doing this expansion in vivo in patients, and they named this procedure SLET. SLET, has shown significant similar success rate as CLET, and that is not very difficult to perform. Works very well in patients with clinical burns, and all that data has been validated. This is the classic procedure where you want to do a superficial keratectomy. All patients with limbal stem cell deficiency, you want to do a superficial keratectomy, clean that surface very well, and then put the amniotic membrane and get the cells from the contralateral eye. You can see here how the patient starts to recover the corneal clarity. So I think it's very important to understand that in patients with purely limbal stem cell deficiency, like the video I show, where there's not significant conjunctival fibrosis that works really well. But in patients like this one, where there is significant conjunctival fibrosis from, like, for example, a chemical burn from a thermal burn, this patient had a firecracker injury, you need to make sure that you incorporate some conjunctival healthy tissue, like a conjunctival allograft, and you can harvest a small amount of limbus from the contralateral and do a sled. So here we placed a conjunctiva from the contralateral area in the area that was most deficient of conjunctiva, and you can see that she's done better. This was done during the COVID times, and we continue to monitor this patient using telemedicine. This publication from our group summarizes what we normally will do in patients with bilateral disease that we decide to do limbo stem cell transplantation. In the past, we used to follow the Cincinnati protocol with gadolinium transplants. Lately, we've been moving more towards the use of allo-SLED, but we continue to use the recommendation of immunosuppression of the Cincinnati procedure. This patient had initially had bilateral chemical burns, and we had done a KLAL in the right eye, followed by a dark, then had years later a rejection, repeat KLAL, did well for a while, but then I eventually failed. So we rescued this with an allo-SLED, and he's done well over the past 3 years with continued immunosuppression. So the outcomes of limbo stem cell transplantations are well known. There's a good meta-analysis and publications like this one from the group of Dr. Sophie Deng, where they show that the most important thing is good control of the inflammation in order to prevent rejection, either with a KLAL or a allogenic SLED. So in summary, I think the most important thing is prevention in those patients with chemical burns. It's very easy to make sure that that doesn't happen by using proper eye protection. Understand the options for unilateral versus bilateral disease, dry versus wet surface. The age of the patient is also going to depend. For example, if it's an elderly patient, it may be better to just move forward with a Boston keratoplasticity if the surface is wet, instead of putting the patient through systemic immunosuppression when there's bilateral disease. And hopefully in the future, we'll be able to offer other biological tissue engineering therapies. So thank you very much, and thank you for your attention.
Thank you very much, Dr. Amezcua. And now Professor Alio is going to introduce the next speaker.
Well, thank you very much. And now we have a very interesting talk from Sayan Basu from India about advanced therapies in ocular surface reconstruction. Sayan, you have your time now.
Hello, everyone. At the outset, I would like to thank Professor Alio and ARI for the kind invitation. I'll be speaking on advanced therapies for the ocular surface and for corneal stromal regeneration. I work in Hyderabad in India, and we work on several aspects of the ocular surface and look at finding regenerative solutions for the adnexa, the conjunctiva, the tear film, the limbus, the corneal epithelium, and also for the superficial corneal stroma as a part of our research profile. I'm very ably supported by a large group of researchers at our center, which includes a group of over 40 individuals, including ophthalmologists, optometrists, scientists, research fellows, and also research ophthalmologists. We are also very ably supported by grants, both from the government and from non-governmental philanthropic support. If you look at the corneal stroma, it is essentially comprised of extracellular matrix and keratocytes. So you can look at corneal stromal regeneration for any kind of stromal pathology. Chiefly what we are concerned about in India is scarring, which is the main cause of corneal blindness in India and other developing countries. So you can look at either an approach which deals with the keratocytes, which form the extracellular matrix, or work on the extracellular matrix directly, or a combination approach where you're trying to regenerate the entire stroma, both keratocytes and the extracellular matrix. So for us to be able to do this work, we have created animal models of several types of diseases of the ocular surface, and which affects the anterior stroma as well. This includes chemical burn models, dry eye models, trauma models, injury models, and we'll try to develop these therapies by first testing these models or these approaches in our animal models. So I'll take you through what we've done with keratocytes first. So this is an approach which involves mesenchymal stem cells. This is based on work that was originally done in the US in Pittsburgh by my mentor, Professor Jim Vanderberg, who showed that mesenchymal stem cells from the corneal, peripheral cornea and the limbus was able to regenerate the cornea, corneal stroma, and remove opacities and cure opacification. This is the work that we have carried forward in Hyderabad, and we have recently completed 2 clinical trials, and these are the first clinical trials that have been on stem cells in India. This is essentially the process of how we get the stem cells. We basically source the cells from, these are allogenic cells from the corneoscleral rims from the eye bank. The limbus is isolated, chopped up, digested, and then cultivated in the lab. When you incubate the limbal cells, initially you get a mixture of epithelial and stromal cells, but by serial passaging, you can get a pure population of stromal cells, which is then sent to the OR for transplantation or application. In the operating room, we basically mix the cell pellet with fibrin glue and use it on the eye. So in my next video, I'm going to show you the procedure for transplantation. This is being done in this case, in a case of superficial corneal scar. We're just using a Vexel sponge to remove the corneal epithelium, followed by which the cells mixed in one of the components of the fibrin glue is being applied superficially as a gel on the stromal surface, and then the other component of the glue is being used to mix it up. And once this gel sets in, this is a, the procedure is done. It takes a few minutes, and it's a completely, minimally invasive procedure. You can see that I'm doing this procedure here in this particular case under topical anesthesia. At the end of the procedure, we put a bandage contact lens, and the patients are given just topical antibiotics for 1 week, no other medications, not even lubricants. And as you can see in the photographs from your left to right, on the left is a preoperative photograph of the scar in the visual axis. You can see the gel with the fibrin glue and the cells on the corneal surface in the photograph in the middle. And on the right side, you can see that a much clearer stroma after the application of the cells. And this is what we have seen in patients, improvement in the stromal clarity and also in regularization of the cornea, and reduction in the reflectivity of the stroma after the application of the cells from between 1 month to 6 months. This continues till a year. So this is typically how it works. Preoperatively, you can see the stromal scarring and opacification in the superficial stroma. Postoperatively, usually this goes away significantly. In addition to the stem cells, we've also been working on the extracellular matrix and of regenerating the extracellular matrix. And we want to use these scaffolds for scarless wound healing. Our primary work is with the hydrogels, which are extracellular matrix based. We have used both bovine source material and human discarded corneas from the eye banks. These have a lot of wound healing properties, and therefore we feel that these gels can be applied in the setting of an active wound, which may be a corneal ulcer, it may be a corneal traumatic injury, and then these hydrogels can help in the corneal stroma regenerating itself without going into the process of repair and scarring. So this is work that we have done in our preclinical animal models, which have shown significant improvement of the corneal stroma with the application of the hydrogel. And a continuation of the 2 projects that I talked about earlier is using both cells and the hydrogel together to form the entire corneal stromal matrix. And this is what we have done through the approach of both compression molding and 3D printing. Here you can see a 3D printer in action, printing essentially a corneal stromal lenticule using the same hydrogel that we talked about, which is derived from decellularized discarded corneas, human corneas. And you can basically print this lenticule into any shape and size, and it can be used either as a refractive lenticule or as a partial thickness graft, or can in many cases also be used for complete replacement of the corneal stroma. We were the first group to develop 3D printed corneas in India. This was achieved in August of 2022, and now we are refining our process of making these 3D printed and compression molded lenticules. And this is our latest product, which is called the neocornea. I'll just play the video to show you how resilient it is. It is not only optically clear, but also very, very tough. And it does not break on mechanical stress. So you see my colleague putting interrupted tenonylon sutures on this cornea, and it just behaves like native corneal tissue. So this is human tissue. This is optically clear, mechanically strong. This is made indigenously, and we think that this will be an affordable alternative to the problem of lack of corneal donor tissue. So in conclusion, we have taken the approach of using stem cells, hydrogels, and biofabricated corneas. We are looking at the safety and efficacy profile, and I think the future is very bright. We'll have cell therapy, we'll have hydrogels for scarless wound healing, and also customized 3D-printed lenticules for refractive correction. Thank you so much for your attention.
Many thanks, Jans, for advancing what is going to be the future of corneal regeneration. And now, María Gesa will introduce the next speaker.
Ahora el profesor Alió nos va a hablar de cirugía cosmética y reparadora de la córnea.
Muy buenas. En esta presentación vamos a presentar un nuevo tipo de cirugía corneal, que es la queratopigmentación terapéutica. No tengo ningún conflicto de interés con esta presentación. Las técnicas de queratopigmentación modernas constituyen un grupo emergente de técnicas que permiten la restauración o el cambio del aspecto estético del ojo, tanto por razones cosméticas puras como por razones cosmético-terapéuticas y funcionales. Estos ojos tienen muy pocas alternativas, puesto que son deformes y tan solo pueden mejorar su aspecto mediante el uso de lentes de contacto, de prótesis oculares u orbitarias, o incluso con una queratoplastia penetrante que evidentemente se va a practicar con mucho problema en casos en los cuales no hay restauración visual posible debido al acceso a las córneas y al alto costo de estas operaciones. Los métodos de queratopigmentación son varios y pueden utilizarse normalmente bien asistidos por la selección de segundo manual, por técnicas automáticas o manuales de detección superficial o asociando ambas a la vez. A su vez, estas se pueden asociar a otros procedimientos oculoplásticos o de estrabismo para restaurar mejor la normalidad estética de estos pacientes. La instrumentación ha sido descrita por Jorge Alió, un servidor de todos vosotros, y se utilizan pigmentos mercurizados minerales que son los mejores para este propósito. Hay distintos tipos de pigmentos, distintos tipos de aparatos también, y aquí os muestro uno para queratopigmentación superficial, que es uno de los prototipos que hemos utilizado en nuestros estudios. Voy a presentaros como ejemplo dos casos clínicos. El primero es de una queratopigmentación asistida por láser de femtosegundo y completada mediante queratopigmentación superficial. Se trataba de un paciente de 55 años que tras un trauma penetrante perdió percepción luminosa debido a desprendidos de retina sucesivos y finalmente un glaucoma. El paciente tenía una deformidad estética, no podía usar lentes de contacto cosméticas y pedía una solución a su problema. Bien, aquí vemos como el paciente tenía una descompensación corneal y una hiperplasia epitelial que vamos a eliminar previamente mediante un pedazo de la misma mediante pinza. Tras de ella vemos una córnea que aparentemente es transparente, pero que está descompensada y que volverá a repetir la hiperplasia epitelial si no la solucionamos convenientemente. Estamos marcando el centro de la córnea para generar una apertura de los túneles que hemos creado con el láser de femtosegundo, expandiéndolos mediante los instrumentos de corte arciforme que hemos diseñado y finalmente configurando el espacio donde vamos a poner el pigmento. Ponemos primero un pigmento verde, del color del paciente era un verde marrón, un color heterocigoto, y vemos cómo este color verde sirve de pantalla a lo que vamos a hacer a nivel superficial. Estamos realizando ahora la disección lamelar de la pupila para implantar pigmento negro que permita reproducir la pupila. Vemos ahora cómo vamos a utilizar un instrumento de queratopigmentación superficial automático con el cual vamos a recrear la pupila de nuevo, puesto que la córnea superficial también estaba parcialmente opaca, y cambiando de punta vamos a utilizar pigmento marrón para completar este aspecto cosmético que ya tenía el paciente mejorado, pero que queremos darle la mayor simetría y similitud con el otro ojo normal. La cirugía finalmente queda concluida. Este resultado estético, como vemos, es muy satisfactorio. El paciente quedó extremadamente contento y ciertamente que hemos restaurado y cambiado totalmente la calidad de vida de este sujeto, este paciente con este enfermedad. Este segundo caso es un paciente joven de 27 años que sufrió un traumatismo en el ojo derecho, tras lo cual perdió percepción luminosa. Tenía a su vez, debido a la antigüedad de este traumatismo, 50 dioptrías prismáticas de exotropía. En este caso vamos a realizar una cirugía de estrabismo que hay que ejecutar antes de realizar la cirugía de pigmentación, porque de otro modo, si no, el pigmento utilizado va a quedar depositado en la tendón y va a provocar una adición indeleble de la conjuntiva. Estamos haciendo un handback, una retrosección con técnica de asas, seguida de una resección de recto medio, y de esa manera hemos alineado el ojo según el cálculo que hemos realizado basado en las dioptrías prismáticas de desviación que tiene el paciente. Cerramos la conjuntiva con bicrin y el caso está terminado. Vamos ahora a proceder a la queratoventación, para lo cual vamos a realizar primero una eliminación del epitelio, un raspado para quitar en lo medio posible los precipitados cálcicos que el paciente tenía. Vemos cómo realizamos este pelado también de las capas superficiales opacas. Marcamos el centro de la córnea y procedemos con un instrumento de queratoventación superficial a reproducir primero la córnea en color negro y después simular el iris en el color más parecido al ojo contralateral. Utilizamos un color mixto también para conseguir la mayor similitud del ojo trazado con el ojo normal. Vemos aquí como los distintos pasos del aparato automático nos permiten ir completando y llenando los espacios que hay que tratar para tener la córnea debidamente pigmentada. Finalmente hacemos un retoque en el área pupilar para reforzar el aspecto cosmético del caso. El aspecto cosmético fue excelente y el paciente quedó también muy satisfecho, puesto que ambos ojos, además de estar alineados, permitían tener una similitud muy grande. En conclusión, las técnicas modernas de queratoventación son muy sistemáticas, proporcionan resultados excelentes con alta satisfacción del paciente, son muy mínimamente invasivos, están casi desprovistos de reacciones adversas si se usan los pigmentos y las técnicas adecuadas quirúrgicas, y se puede combinar con procedimientos cosméticos reparadores como cirugía del estrabismo y también cirugía palpebral. Aquí os pongo una referencia donde hemos reportado los resultados de 234 casos en Precisional Ophthalmology, en los cuales demostramos la estabilidad de estos resultados, los buenos resultados que hay en cuanto a segregación del paciente y la buena oportunidad que tienen muchos de ellos en restaurar una situación cosmética por un método terapéutico que es muy adecuado para estos casos. Nada más y muchas gracias por su atención. ARI23.
Muchas gracias, profesor.
Now it's my pleasure to introduce John Marshall, who will talk about new corneal stromal surgery. Thank you, John.
First, I'd like to thank the organisers, and in particular my friend and colleague Jorge Alio, for allowing me to give this presentation. I call this a tale of two helixes because I've always been amazed at conservation in evolution. DNA has been a fundamental element in evolution for many millions of years, and collagen was first seen in the cornea over 500 million years ago. So when nature gets something right, it tends to stick with it. It's perhaps not surprising when we look at the cornea throughout the animal kingdom, it's absolutely the same structure with an epithelium on one side and endothelium on the other, and the vast body of the cornea being made of collagen fibers in the stroma. In all animals, the superficial third of the cornea tends to be stronger with a degree of interweaving of fibers, and the posterior 2/3 have lamellae which are beautifully arranged at approximate right angles to each other and are thought to be fundamental to the possibility that the cornea is transparent. Now, sometimes things go wrong, and we know that the genetics of the cornea can go wrong, and indeed do so, and lead to conditions like keratoconus. We now have a much better understanding of the genetics and already have identified numerous genes involved in these diseases and can generate risk factors to identify patients who are at greatest risk. I think it's extremely important to understand that a man-made intervention has made some really significant problems for the cornea, and we're seeing that in relation to refractive surgery. Superficial procedures such as PRK or LASIK for a 6 diopter correction will cut through approximately 5 million collagen fibrils. LASIK, on the other hand, the flap alone will cut through over 200 million collagen fibrils. So it's perhaps not surprising that many of us have been a little bit concerned about the structural integrity of the globe after such procedures. Now, one of my colleagues, Abby Wilson, has worked on this using interferometry and has been able to show that all forms of refractive surgery weaken the biological integrity of the globe, PRK being the least invasive, SMILE dependent on depth is the next, and the worst culprit for disturbing the system is LASIK. As you will see in a moment, we can actually reverse this procedure in a sense by cross-linking and other methods if we are introducing new tissues into the cornea. So, in summary, for the last 30 years, whatever the intervention in refractive surgery, we have weakened the cornea. We have effectively taken away a lot of its intrinsic strength. The next 30 years, I hope, will be a complete change, and I hope that we'll see much more attention paid to strengthening the cornea. So the path has already been laid by Theo Zeiler with cross-linking, which certainly strengthens the cornea. But I think the real future is going to be in additive surgery, whereby we place stromal tissue into the stroma, having undertaken corrections on the lenticule prior to its insertion. Obviously, our better understanding of genes is also going to help us improve our procedures. Now, currently, there are 2 major players in this field, one led by David Muller and Michael Merkin, and they are using human tissue, taking human donor material and processing multiple lenticules from a single corneal donation. They then double E-beam irradiate that and have been using that to insert into human corneas. Now, I've taken a very different approach because it amazed me that pigs are used throughout surgery but haven't been used in the eye until relatively recently. For many years, we've seen heart valves in cardiovascular patients, and indeed, we've now seen pig hearts being transplanted. Pig skin has been used to treat burns victims, and now we're seeing pancreatic cells in order to treat diabetics. So I think George Orwell was right. All animals are equal, but some are more equal than others, and pig are at the top of the list. Now, why do I think that's important? Well, America is the only country that has sufficient cornea donated for its surgical needs, and they get approximately 80,000 a year. Europe, on the other hand, is not doing nearly as well with 33,000 corneas donated in 2020. But look at the number of pigs killed in the European Union. 124 million in 6 months. So there's no shortage of pig material. Now, I was really quite amazed at this. And if we're going to use pigs, what do we need to do? Well, clearly the first thing we need to do is to remove all the cells, but we need to retain the stromal matrix to give us strength and material to play with. We can remove the cells by solubilizing the membranes using enzymes, and then with repeated washing, we get rid of the debris, including antigens, epitopes, etc. We can then take that entity and we can change its shape. We can change its shape with lasers. We can stiffen it with cross-linking, and we can sterilize it. And already we know we can increase its strength by up to 200 times, which is probably too much. Xenia have taken this process through good medical processing, and already, having addressed all those issues, now have a corneal implant which is MDR approved, custom-made device that's fully compliant with the European regulations and available throughout Europe. So what can this do? Well, I call this stromal supplementation surgery. Presumably one could do onlays, but we've concentrated on inlays. And essentially you have to introduce it into the stroma, but once introduced, it will cause the change if you need a change in refraction, but it will certainly increase strength. Now, this is slightly out of date, this slide. There are over 100 Xenia implants now, with the longest follow-up for 4 years. One of our collaborators, Marwan Gabra, has come up with some interesting observations. The first being, how deep should we insert this? And I think we should insert it in the deeper 2/3, not the superficial 2/3. How are we going to put it in? Well, I don't think we should be using a femto, because in that area of the cornea, it's very easy to delaminate tissue. So many studies have shown that you change the biomechanics of the cornea, for example, in LASIK, when you cut the flap, not by the bed, but by the edge cuts alone. And you can see in this slide that the edge cuts are almost identical to the full procedure. If you just delaminate, there's virtually no change in the biomechanics. So finally, I want you to follow this tale into the future, because I think additive surgery is going to be really the basis for refractive surgery in the future. I'd like to thank all my colleagues, and I hope you found this of interest.
Thank you very much, Jan. This is a most interesting issue and will be part of the future of corneal surgery. Now we're going to have everybody aboard, and Jose Well, who is now virtually with us. Hello, Jose, do you hear me?
Good morning, Jorge. Good morning.
Hello.
Pleasure to be here again.
Luis. So we have a short time, but we have a very interesting debate that I'm sure that you would like to control and to chair as well, because there are many issues that will be important for the future coming from the presentations that have been done today. So, which is your opinion about the different topics that we have been discussing, and you have the speakers around just to make any question.
Okay, well, let's use the expertise and the opinion of the panel of debate that we have in front of us. Let's, if we can, comment on each of the talks. And the first, the keynote from Rohit was very, very interesting, but I think that we all missed the autologous serum. He was talking about anti-inflammatory drugs, insulin, and I would like to know your opinion, the panel opinion, on the use of insulin versus the use of autologous serum. Perhaps Nuno, Jorge, or Juan, or yourself, Jorge Senior. Which is your opinion? You have a strong experience using blood derivatives, and so how do you see them in front of the use of insulin?
Good morning, everyone. Could I start by making a short remark on this topic?
Of course.
First, thank you for, I think the presentations were excellent. I think that this question is also what I wanted to comment on. So to me, insulin drops are different from blood derivatives because insulin drops are mostly used as short-term, should be used as short-term treatment for pathologies such as persistent epithelial defects and such. So it's not for long-term use, whereas blood derivatives, and particularly a new thing that we are also working with, which is amniotic membrane extracts, these two types of drops can be used in for longer times. So my experience using insulin drops is for persistent epithelial defects and neuropathic keratopathy, which are delayed healing, and this provides them with faster healing between 1 week and 10 days. So this is what I believe. These are two different things. One is for short term, and the other one can be used for long-term treatment.
And can I make a note on this?
Yeah, of course. You are the one who should do.
No, thank you. I agree with what was said. One of the important aspect is when you have any insulin has tendency to have more of nerve growth factors. So I agree with what he said. The nerve growth factors are missing or have a challenge in your neuropathic or nerve-related challenges. But when you look at amniotic or an autologous serum, you are looking at nerve growth factors, anti-inflammatory, and it also has growth modulators, which even help in remodeling the extracellular matrix. So insulin cannot do all these things, but autologous serum can do all this. So the band of action based on the work, biomarker, and other profile we know is more larger in an autologous serum compared to a smaller band of functional work when it comes to an insulin drops. This is what I know from my work.
Okay, so it's a good conclusion. So you think that both things might be used in the initial phase, and for the chronic treatment, probably blood derivatives would work better, no?
Thank you.
Okay. Well, then moving to the Guillermo's lecture, he has had a strong experience for many years with SLED, and we all have seen his technique, or the technique that most surgeons are using worldwide, which is the use of amnion, and then the use of these small pieces of the contralateral limbus of this unilateral patient. My question to you, especially, for example, to you, Juan, probably you have experience on that, is that what about, instead of taking this small biopsy and creating multiple small pieces, leaving distributed in all the amnion surface, why don't use or take this same biopsy and divide in 2 or 3 pieces and locate these 3 pieces in a prepared, let's say, bed in the recipient at the limbus area? This is the technique that I am using, and I think that it works at least as well as these multiple pieces that I always am afraid that they might be lost. So what do you think, Juan?
I think exactly like you. I have no experience with the SLED because I've always prepared two small pieces of limbus around 2 o'clock hours in the upper and the inferior part of the cornea, which are the most high density of stem cells in the donor eye. And then I put also in the superior and inferior part of the cornea. In my experience, it works very, very well. I am afraid of losing some islands of cells that if you put in a SLED, of course. Guillermo has a very huge experience, but I don't have experience with the SLED because this, like macroscopic type of surgery in my hands has worked perfectly. So
okay, it's quite
this is my answer.
It looks like that we have prepared this question, but we haven't.
No.
We never talk about that. So
I started maybe 25 years ago, and I still continue the same thing.
Okay, that's curious. Okay, Jorge Alio Jr., do you agree on that?
Yes, basically my concern with the SLED is what you said, that you are putting the stem cells, but you are not restoring the anatomy. You're not restoring the needs. And the thing is that the autologous conjunctival limbal autograft works so well that when you have one absolutely healthy eye, basically it's difficult to really don't do what is proven by 30 years that absolutely works with no risk for the donor eye. So that's the reason why I think it's much better to restore the anatomy and the niche rather than putting on. Other thing is the allogenic SLED could be an option, but once you have a healthy eye, I think I fully agree with what you said.
Okay, let's move to Sayan Basu. It's quite curious, but I perhaps it was a personal perception, but he was focused basically in restoring the stroma. He mentioned that he restores the surface with, so he took a biopsy from the limbal cells, and from that he recreates the stroma, but he doesn't spend too much time talking about how he uses these limbal cells to restore the surface. And I presume, I don't know if Sayan is online, but I think that he's not. But have you had the same feeling? You all as panel of debate.
I know quite well Science versus work, and it's true that in the end, his major research focus is in the regeneration of the stroma by the superficial implantation of the corneal stromal stem cells. For limbus, Margarita Calonge has a very nice group, a very nice work in order to restore the epithelium with mesenchymal stem cells. But I think science is mainly focused with the stem cells on the stroma. Also, although he developed the SLED things, etc. But I think it's his main research focus.
Yeah. It's what it looks like in his talk. Well, anyway, if he's not here, he cannot respond. So let's move to the Professor Alio talk about cosmetic. Just a quick question, Jorge. I think that these cases are wonderful, and I think this is a real help to many of these patients. As you mentioned, not only anatomically but also psychologically. But my fear is that having seen your surgery, is relatively frequent or not to have after the surgery significant epithelial defects, or do you have problems on that, or the epithelium grows over these areas nicely, or what?
This is a very interesting question, and my answer is, in the many cases we have done, we have never had a chronic epithelial defect. This is remarkable, and I think that in one way or another we are creating a new ocular surface scaffold for epithelial cells to cover. Obviously, we have never done this in cases with neurotrophic keratitis or patients that have no corneal sensitivity, because they will be negatively affected by the surgery. But as far as you have good corneal sensitivity, be sure that you will not have any epithelial problem, something that was not known at the beginning. But it's true that in the complications we have reported along the 14 years in which we have been developing this technique, we have never had epithelial cell problems. You have to adapt a contact lens, and then this contact lens is removed after 2-3 weeks, and the cornea is completely healed. You have a corneal irregularity indeed, but the epithelium is not a problem and is not ulcer. And is not ulcering afterwards. So this is another remarkable thing. There is no long-term epithelial problem at all.
Well, this is then, if this is the case, Jorge, which you must understand that it's difficult to swallow because of the, as you remember, the experience in the early 90s using epi donors. The main problem with these synthetic superficial lenticles was that epithelium was not able to properly cover these lenticles. So if you have not had that, perhaps you can consider to use a similar material but transparent in order to give some refractive effect, and then just leave it on the cornea and leave the epithelium growing on. So perhaps there is something in the materials that you're using that allows the epithelium to grow in a healthy manner. And if this is the case, well, perhaps using a transparent one can be a good option for example, aphakic correction, and use a transparent lenticle with this material or a similar one, and allowing the epithelium to grow in and come back to the epikeratophakia procedures. So you should think on that.
Thank you very much, Jose. This is something that will come in the future. There are many open areas for clinical research, and this is one of those. Thank you. And well, we need to close the session. We are out of time. I think that it was a great session. Thank you, Jose, for the great discussion as well. And I'm sure that next year we shall have another ocular surface session as good as this one, because the topic is huge. Thank you very much, and the session is closed. Thank you.